Okay, so I'm recording now. Okay, so this lecture is really like a big definition one. You know how like the definitions when we start off with things? The infection, inflammation, immunity, all these things, you're gonna see this come up in all the clinical medical areas that you're gonna be learning about. Whenever they talk about acute inflammation, it's this. When they talk about chronic inflammation, it's this. Sorry, I keep spinning. So this is just going to be a big kind of like definition thing. These are some of the objectives that we're going to go over, all the different topics that we're going to go over, talk about injury, reversible or irreversible injury, what happens when cells die, how do they die, talk about inflammation, acute and chronic. We'll talk about sepsis, immunity. This stuff we'll probably deal with tomorrow, not all today. So physiology, again, dealing with the functions and vital process of all living organisms. Pathology is the abnormalities, but then pathophysiology is what we're studying in this class, and it's methods used by cells to respond to stress and disease. How are they responding to the disease? Stress, what happens to that tissue? And that's what we're going to be learning as we go through this course. So how do cells adapt? Okay, they're going to respond to persistent stress that's not lethal. Obviously, if it's lethal, you're going to kill the body. There's nothing to respond to anymore. But it occurs in response to a bunch of different things. Normal or physiologic conditions. If we say something is physiologic, that is a normal response. It's supposed to happen. So, pregnancy. Obviously, the demands go up for pregnancy. You're going to have maternal adaptations, but those are physiologic. It's normal. If you are exercising a lot, okay, and your muscles get bigger, your muscles getting bigger, hypertrophy is a response to the stress that you're doing by working out, lifting all those weights. But it's a physiologic response having your muscles get bigger because it's a normal response of exercise and it's healthy. Now look at, you have adverse or pathologic conditions. Hypertension. Okay, hypertension is not normal. This is a very thick heart. This is hypertrophy that is abnormal, pathological, because it's caused by hypertension. And we also have reversible cell injury. This could be due to irritation, like examples are irritation. Asthma is reversible because you have the attack, you have the inflammation, and then it goes away, it reverts back to normal. That is a reversible injury. Irritation, if you get a scratch, irritation, it goes away after a few days, but it's reversible, it goes away. So how do our cells adapt? We can have atrophy, which is decrease or shrinkage in cell size. We can have hypertrophy, where they get bigger. The cells themselves just get really, really big. Hyperplasia is increase in the total number of cells due to an increased rate of cellular division. So hyperplasia, we have abundance of cell growth now. Metaplasia is a conversion of one cell type to another. So a lot of your cancers cause metaplasia. And the last one is dysplasia, which is disorderly growth. And you see the pictures there, kind of describing the different ones there. So again, you have to classify these changes. Is it physiologic or is it pathologic? Is it due to an underlying pathology or is this a normal response to whatever they're doing? So physiologic, again, increase the size of the uterus due to pregnancy. Yes, it's going to have to get bigger. It's a normal response to pregnancy. Increase muscle in response to weight training. Your pathologic conditions, thyroid enlargement due to abnormal thyroid function. That's a pathological condition causing the thyroid to get bigger. Increase in breast size in males due to tumors. Okay, pituitary tumor. Which one? Let's go back to physio and review. What hormone in the pituitary is going to cause increased breast tissue in males? Prolactin. Remember, what does prolactin do? Milk production. You're going to have to get bigger glandular tissue to provide milk function. So in men who have pituitary adenomas, they get growth in breast tissue. So atrophy, cell shrinkage is reduce their function in response to injury. Cause, disuse or reduced functional demand. Do you ever have a cast on your arm or leg, and then you take it off? That muscle has gotten smaller than the other side because it was in repair, it was disused, there was no function with it. You lose muscle mass. Denervation. Okay, remember, your muscles will not contract without nerve impulse. So if you cut the nerve to those muscles, that muscle will never contract again. The muscle's not being used, it's going to wither away and go away. That's atrophy. Ischemia, lack of oxygen to tissue. If you don't have oxygen, you don't have blood supply to a tissue can't survive, you get atrophy. Nutrient starvation, anorexia is an example of that. Any problem with your endocrine signals can cause atrophy, cell injury, and obviously aging. Hypertrophy, increase in cell mass with a change in functional capacity. Okay, obviously as a result of increased demands, so they have to generate more tissue to do all that. It subsides when the increased demand is removed. So if you work out a lot and then you stop weight training, eventually that muscle mass will start to go away because the demand for having that amount of muscle mass is gone because you're not working out anymore. Important for cells that are not able to undergo mitotic division. If they can't split anymore, the only way they can get more of it is to get bigger. So hypertrophy, okay? Differentiated muscle cells, they can't split, they just get thicker. That gives you bigger muscles. Hyperplasia is an increase in the number of the cells, occurs in cells that are capable of mitotic division. Okay, so fast-growing cells. That's why cancer drugs attack any fast-growing cells with mitotic division. That's where a lot of these cancer drugs aim. What are fast-growing cells in our body? Hair. That's why they lose their hair follicles, because it's killing off any fast-growing cell. It doesn't know which cell it is, anything that's fast. Tumor cells grow fast, hair cells grow fast, let's knock them all out. So again, what can cause this? Increased physiologic demand, so erythropoiesis in high altitudes. Okay, that goes up. Hormone stimulation. Okay, estrogen increases the stromal cells. That's during what's it called? Egg maturation. And persistent cell injury. Calluses. People who work out, do a lot of barbell training, they get calluses on their hands a lot. Repeated injury to the tissue, it grows and gets thicker, and you get keloids, you get scars, stuff like that. That's all hyperplasia. Show you a picture here. What's going on? We lose Wi-Fi. Hold on. Okay, so this is an example of hyperplasia. This is gingival hyperplasia. There are some conditions you'll read about later on that with certain antibiotics can cause gingival hyperplasia. So that's overgrowth of cells, too many cell growth, lots of numbers of cells. Metaplasia, replacement of one cell type with another due to persistent injury. Okay. It's reversible if you remove the offending agent. However, you can cause some cancer to form as well. Anytime you have abnormal growth, replacement of one cell with another, when you start replacing these cells, if the genetic transfer doesn't happen right, you get mutations, cancer growth happening. Smoking is one of them. Okay, the reason why smoking is so bad, chronic irritation of the bronchial mucosa by constantly inhaling the smoke. What does it do? We have our ciliated columnar epithelium. If it's ciliated, what does that mean on it? Cilia, what are they? What's the function of cilia in the lungs? Motility, get the phlegm out of you, right? All that the pathogens get trapped in there, and mucus gets there, and you cough and you phlegm it out. When you smoke a lot, those ciliated columnar cells are converted to stratified squamous epithelial cells. Guess what they don't have? Cilia. So all that stuff just gets stuck in your lungs, you can't cough it out, and you start causing abnormal growth, metaplasia, and you get cancer cells. You're replacing the cell types. Here is an example. This is a cervical swab. So when you get pap smears, they're scraping the cervix to get cells to see what's going on. If you see here, this is the way that it's supposed to be. Okay, covering epithelium is columnar. You can see how nice and even everything is going along that side of those cells. Now, let's look at the squamous metaplasia. Look how disordered everything is here. These cells do not match the same border as the one on the right. This is metaplasia. We're changing cell types with something else. Dysplasia, disorganization of the cells due to variation in size, shape, and so forth. Often occurs in hyperplastic squamous epithelium and in intestinal mucosa, therefore, again, cancerous or potential to be precancerous. If the entire thickness of the epithelium is involved, it's called carcinoma in situ, or it's still like, inside. Does not invade the basement membrane. And I have some pictures to show you in a second. But in time, it can progress to a full-on invasive carcinoma. So we have here different progressions of cancer growth. First, we have normal, then hyperplasia, then you have your mild dysplasia, disorganization. Now we have all these green cells are the cancer cells. And these cancer cells are still inside the tissue, in situ. They're still inside. This dark red cell line is the basement membrane. This is keeping it inside that tissue. Now we have invasive cancer. All these cancer cells broke through the basement membrane, and now they can spread to nearby tissues, or if they get into the lymph system or the blood, they can travel to other parts and called metastases, when the cancer spreads from one location to another. Can't happen until you get invasive cancer, because right now everything is still in situ. This is the goal. You want to just remove the entire tissue because it hasn't spread anywhere. So you try and capture the entire cancer cells in that tissue. Okay, those are ways that cells can adapt to injury and stress. Now let's talk about irreversible cell injury. Now this is all or nothing. Two things that happens to a cell. It can be necrosis, caused by ischemia or toxic injury, or apoptosis, just cell-induced suicide. This cell dies off. Obviously, apoptosis is better because nothing really bad happens, but necrosis, we're going to spend a lot of our time talking about this. So again, here's your apoptosis. The cell just shrinks. You get budding, and then eventually it just breaks up into little pieces, and then the macrophages come along, eat them up, and they go away. Necrosis, however, the cell swells. It starts getting really big and filled with all this nasty stuff. Then, as it swells too much, it becomes leaky, and eventually you get cell lysis. Cell breaks apart, and all the products inside get laid out into the blood or wherever tissue that it's in. So, with necrosis, there's 4 different types of necrosis. This is where the pictures get nasty. But again, this is the time while you're in school, desensitize yourself to things that you don't like watching. You are in a medical field. You can't just pick and choose what cases you want. They're all going to be random. You just got to show up. That's what you get. So you're going to be seeing some weird stuff. So there are 4 types of tissue necrosis, and it depends on the type of tissue that's affected. Coagulative necrosis, usually caused by anoxia. You'll see this in solid tissue and muscle. We have liquefactive necrosis. This is a pyogenic bacteria. They cause high fevers, and it basically melts the brain. So usually the brain is usually that one. You can have fat necrosis as well. This has to do with pancreatic injury. Remember all those digestive enzymes that are from the pancreas that go right into that duodenum. You can get fat necrosis, and that happens in the pancreas and in adipose tissue. And the last one is caseous necrosis. This is from tuberculosis and fungi, and that's usually in the lung. Okay, so here's some pictures. Here's liquefactive necrosis. You can see where all those arrows are. They're kind of demarcating an area, and you can see how that tissue inside that red area is different than the other side around it. It's liquefactive necrosis, turning it into liquid. And you can see in the brain, you're having an area missing. It's like Swiss cheese, because that liquefactive necrosis, probably due to a stroke, or they had really, really bad infection, caused liquefactive necrosis of the brain. This is caseous necrosis. This is due to TB, tuberculosis. You see, this is all normal, but all this in here, that's all that nasty, broken down tissue due to the necrosis that happened. And we get to now gangrene, which is one of the most common things that you'll see, due to interruption of blood supply to a large area. So, big vascular vessels in the legs, like the femoral arteries that feed the legs. If you start getting problems with vascular integrity, you're smoking a lot, really bad uncontrolled diabetes, you're going to compromise your vasculature, the blood flow going to your legs. You'll see this a lot in diabetics who don't take care of themselves. They'll get gangrene. But there's different types of gangrene and they have different causes. The first one is called wet gangrene. This is your liquefactive necrosis. Wet gangrene. Usually affects your internal organs. Very, very foul smell. Often results from wounds, burns, traumatic injuries. They have a lot of bacterial growth, and they're going to have a lot of pus. Okay, that's why it's wet, and you'll see pictures of that in a second. When I was on rotations, we had a patient come in with osteomyelitis, which is an infection of the bone, but it spread to the skin, and it caused wet gangrene. And he was sitting in bed with a blanket over his legs. So obviously, you have to inspect the legs. When I pulled the blanket off, like that wave of like hot smell, nastiness just comes right out. They smell really, really, really bad. Dry gangrene or coagulative necrosis. They're going to have black, wrinkly skin with a distinct line of demarcation. You will see on this picture that I show you, you have normal tissue, then all of a sudden there's a line and everything above that is black. That is dry gangrene. It looks dry. The wet gangrene will look wet, and I'll show you pictures in a second. Dry usually going to happen more in diabetics, autoimmune disorders, often in the hands, legs, or feet. Not associated with an infection. Very important. Dry gangrene is not infectious. It's usually due to clots in the area, poor circulation, stuff like that. The last one you can have for gangrene is gas gangrene. Okay, what is it what you're looking for when you start pushing on muscles? You want to hear something? You're listening for something? Crepitus. What's crepitus? What does it sound like? Or should it popping noises? Well, gas gangrene, you have gas bubbles. And when you're feeling for gas gangrene, if you hear bubbles, popping, snapping noise like Rice Krispies, when you add milk to it, it could be gas necrosis because of the gas bubbles, and you're popping those bubbles. So, big things. This is an important one as far as differentiating between wet and dry gangrene. Remember, dry has no infection. Wet is from an infection, bacterial infection. Other things, obviously, you have a lot of liquefaction, offensive odor of the wet gangrene, swollen, red, and warm. Remember, the underlying cause of the wet gangrene is an infection. They're going to have signs of an infection, the redness, the warmth, swollen tissue. Wet gangrene also usually happens pretty fast. whereas dry gangrene is gradual, takes a long time to happen. The treatment for both of them is the same: surgical debridement and amputation, depending on how bad the gangrene has become. But you have to debride it, you have to get rid of that dead tissue, the signs of infection, wash all that out, and then depending on how severe the gangrene is, they may need amputation. So here's some pictures. You can see dry gangrene has this line right there. That's that line of demarcation where you have normal tissue and all of a sudden it's black toe. Black, dry, wrinkly toe. And here's your wet gangrene. Very, very wet looking, macerated, breakdown of tissue. There's no distinct line of demarcation. But those are the major examples between dry and wet as far as how they look. And as far as gas gangrene, again, you don't have to go through all the details of this, but just know that obviously it's gas gangrene. They're making gas, which are going to be trapped in bubbles, and when you pop those bubbles, it gives you that sound of crackling, and that's what gas gangrene is. And here's another example of what gas gangrene is. You can see how that thing's pretty built up and filled with air, probably. So what predisposes you to gangrene? Diabetes is the big one. Atherosclerosis, smoking, peripheral vascular disease, frostbite. Frostbite, when you see the people with the black noses and all that stuff, that is a dry gangrene. That tissue died off due to lack of blood supply because all your blood was going where? To your core, to keep your vital organs warm. Remember, the body doesn't care about your toes, your fingers, or your nose when you're freezing. It cares about the core. Okay, apoptosis, that was all necrosis. Now we're about apoptosis, that programmed cell death. Remember, they are not ruptured, but they're ingested by other cells. So there's no inflammation going on because they're not rupturing. They're not getting rid of all the contents in the cell and just putting it out there. No, they're turning into little buds, little packages, and those just get eaten up by neighboring cells, and it goes away. There's two different pathways through which apoptosis is induced. We have the extrinsic or the environmental signal and the intrinsic, which is cellular. Any questions about cell death? What happens when cells die? Okay, mechanisms of cell injury. How do cells get injured? So we have two different ways. We have internal. Here's your tissue necrosis. Immune reactions are internal causes of injury. The external ones, obviously, infection is going to be there. Okay, trauma can cause cell death. Physical agents, burns, frostbite, irradiation, chemical agents. You get chemical burns that cause injury to cells, and obviously foreign bodies. So ischemia and hypoxia. Tissue hypoxia is referring to what? Lack of oxygen. Caused by ischemia. What is ischemia? Lack of blood, not oxygen, just blood in general. But blood, we know, obviously has oxygen in it, and if you're not getting any blood to an area, those tissues are not going to have any oxygen, and they're going to start to die off. Some damage is reversible after reperfusion. That's why if you're working in the ER, they say time is brain or time is heart, time is tissue, because the faster you can reperfuse the heart from that blockage or the brain, the better you are. However, what they're noticing is sometimes you can have what's called a reperfusion injury, where you had an area of tissue that was blocked off for a period of time, whether due to a clot, obstruction, whatever, but that tissue wasn't getting fed oxygen. What's going to happen to all that tissue if there's no blood in that area? What are they going to start building up a lot of? All those waste products and the signs of inflammation, they can't get out because there's no blood supply. So they start building up in that tissue. But once you reperfuse it, all those products now can get access to the blood and they can get out. So what they find is that sometimes you can get what's called a reperfusion injury, where you now put the, you did a stent in the heart, you reperfuse that tissue, blood is going back to that area again, you gave a clot-busting drug to the brain, and now the blockage to the cerebral vascular arteries is open, blood supply goes back, But three things can happen that can cause a reperfusion injury. One, calcium overload will cause a reperfusion injury. Formation of free radicals caused by the ischemia and the hypoxia. All those free radicals are going to get back into the bloodstream once you reperfuse, and they can cause problems just by being free radicals. And you can also get some inflammation as well. So when I talk about reperfusion injury, calcium overload, free radicals, and inflammation is what causes reperfusion injury if they get it. So again, talking about reperfusion injury, eventually all ischemic tissue will become necrotic. You don't have any oxygen, no blood supply, no healing factors, no way to wash out your waste products, your cellular necrosis. But again, these new techniques that when the blood supply is restored, there is some injury going on. Again, mostly due to free radicals. Infectious and immunological ways to cause injury to your cells, obviously viruses and bacteria. You can have direct injury with enzymes, exotoxins, and endotoxins. Clostridium perfringens is an example of an enzyme. Clostridium botulinum, is that Botox, is an exotoxin. E. coli is an endotoxin. I'm not going to ask you for these things on my exam, but you will probably have it with Professor Stewart in micro because that's right in micro's wheelhouse. The indirect injury is what your body's immune response is. How does your body react when you have one of these issues? And that indirect injury can cause problems as well. Not directly caused, but the process of our body recovering from these things can cause some injuries as well. Nutritional problems. Okay, if you're deficient in iron, you may have a problem with your red blood cell development because they need iron for growth. Vitamin D, if you're lacking vitamin D, you have a problem with your bones. Obviously, hopefully, y'all remember why vitamin D is important for the bones. Others are general, B12, your folate, metabolism, DNA synthesis, vitamin C, antioxidants, and so forth. So again, by having lack of these nutritional components can cause problems with cell types. Chemical burns and cause problems, obviously direct and indirect injuries, and environmental issues, air pollutants, heavy metals. This is why it's very important in your history taking, depending on what kind of complaints that they're having, knowing what they do for work. Because if you find out what they do for work, and let's say they're a house cleaner. House cleaner with chemicals all the time from cleaning everything. They may have a workplace injury from doing that. I know Mad Hatters, they don't make hat with lead anymore, but they used to make hats with lead. That's why Mad is a hatter, like Alice in Wonderland, because he was crazy from the lead from making the hats. Again, it's an environmental injury from his workplace that caused his physical problems. If you don't ask those questions, what your patients do for work, what do they do, you won't know. They may be having, access or getting pollutants, other things in their bodies just from work. Are they on any drugs? What are they taking? Cleaners, that's what I mentioned before, and obviously toxic gases, carbon monoxide. What are they doing for work? Physical, mechanical burns. You obviously have your thermal, hot and cold. Atmospheric changes, high and low, can also cause physical and mechanical things. Electrical and obviously radiation causing burns will cause, tissue injury, of course. Radiation, what happens when radiation happens and we are bombarded with radiation for a long period of time or a lot of it all at once? First thing that happens, we get some radiation damage, but over time, again, you don't have to know this by heart. Just understand that, yes, radiation causes tissue changes. After hours, you start getting these cell function fates, cell death, or genomic instability. And then weeks to years later, they start getting cancers, other things pop up. So whenever you see these environmental damage, like the Chernobyl accident that happened in the 80s, the people that lived in those areas, they started getting high rates of cancers because of the radiation that they were exposed to. Free radicals. We talked about free radicals before when it came to reperfusion injuries and these free radicals coming out all the time. Basically, free radicals when an atom loses an electron. So that becomes a free radical. What causes these free radicals to happen? Inflammation, ischemia, and obviously toxic chemicals and poisons cause free radicals to happen. What do? Attack membrane structure, denature proteins, and cause our DNA to rupture and unravel. So free radicals are not good. We don't want them around. And they're implicated in diseases of the joints, hearts, kidneys and lungs. May play a role, obviously, in mutations as well. So free radicals, we're always trying to avoid those free radicals. Moving on to inflammation. So what is inflammation? It occurs when the cells are injured. We get an area of inflammation. Inflammation by itself just begins the healing process. You can have acute inflammation or chronic inflammation. Acute responses, septic arthritis, bacterial pneumonia. Again, just an acute situation. You're sick. You're getting inflammation from being sick. Your body responds. But once the underlying agent goes away, the inflammation should go away as well. Chronic inflammation will result in scarring and fibrosis. So whenever you see the word scarring or fibrosis, that is permanent tissue damage. That's not coming back. So whenever you see the word scarring, fibrosis, that tissue was damaged, it didn't heal right, or it just never could heal right, and you get scarring and fibrosis. If you have a heart attack, that tissue in your heart is dead. That tissue will fibrose afterwards because your heart can't regenerate. The muscles don't divide. So you can't regenerate heart muscle. So from chronic inflammation, it's going to scar and fibrose. Three purposes of inflammation: neutralize and destroy the offending agent, limit the spread of that offending agent. We want the inflammation to be localized. This is localized inflammation. It's just in that lower leg. Okay, I don't know the rest of the picture of this guy, but from what we can see, that's his inflammation. It's acute. It just localized that one area. Okay, so there are 5 cardinal signs of inflammation, and you have to know these both in Latin and the other one. So redness is rubor, swelling is tumor, heat, calor, pain, dolor, and loss of function is functio lesa. These are the 5 cardinal symptoms of inflammation. In this section, we're going to go through why do they have these complaints? What causes these 5 things to happen? So, inflammation and pathogenesis, what happens? Increased vascular permeability. Okay, and we're going to go through these in steps, so we'll break them up. Second one, recruitment and immigration of leukocytes. And the third thing that happens is phagocytosis of that offending agent and any cell debris. We clean up the area, and it's ready for healing. So the first step, vascular permeability. Why is this important? We need the healing factors to get out of the vessel. So by having increased vascular permeability, it allows those bigger molecules, the neutrophils, the macrophages, red blood cells, to get through the vascular wall to get into the area where the damage is. We get vasoconstriction of the arterioles near the injured site. Why is that important? Prevents the spread of the infection. It also prevents washout of those healing factors. We want all that healing stuff to stay in the area of the damage. If you have wide open vessels on both sides of the injury, blood's going to go too fast and get washed out of all that stuff. If you vasoconstrict both sides, the blood's going to stay in the area of damage longer. All those healing properties in the blood have time to get in and heal up that damaged tissue. We get chemical mediators that are released. Histamines, prostaglandins, and leukotrienes. Okay, histamines, what are they going to do? Talk about histamine a lot. Called swelling. Remember all that fluid? Remember you have histamine, the snot going everywhere. Okay, with areas of swelling, histamine plays a role in that swelling, that vascular permeability, as allows the fluid, all that histamine to get out of the vessel into the tissue, and that gives you your swelling with the inflammation process. We get vasodilation and increased permeability within the area of the injury. So we get vasodilation, so the vessel gets bigger, increased permeability, so that we can get things moving. Fluid is pushed out of the vascular space into the interstitial space. Again, that's the localized swelling that occurs. And blood flow is increased to that area, and that causes the redness. Because there's more blood in that area, more blood, more red blood cells gives you that red color, because red blood cells are there as well. Okay. Okay, moving on to the leukocytes now. So first we talked about the inflammatory process with regards to vascular permeability. Now let's talk about our white blood cells, the leukocytes. We get increased blood flow to that area, bringing in neutrophils, and that's called chemotaxis. You can see it's right here, chemotaxis. Next, you get this margination or pavementing. What happens is all these white blood cells start to line up against the vascular wall, and they're waiting to get pulled into the interstitial space to do its job there with the infection. The next thing that happens is those white blood cells have to get into the interstitial space, and the process is called diapetes, diapetesis, or immigration. And that allows the white blood cells to go through the vascular wall into the tissue where the infection is, so that the neutrophils can start doing their job. So this is the second phase. These leukocytes start to come into the area. They line up, margination, and they get through the wall, immigration. So neutrophils and the monocytes produce enzymes that will digest protein structure. At the end of the inflammatory process, the neutrophils die off, and then the macrophages come in and they clean up all the area. Okay, macrophages, big eaters, they eat up all the different debris and clear out all the area of the pathogens. Prepare the site for healing. Okay, so this is the summary slide, and we'll take a break after this. And it kind of goes through what happens and why do we have those cardinal signs of inflammation. So start at the top. We have an injurious agent, cells are damaged. You cut your finger on a glass, so you have, and now we have an open wound. We know we release leukotrienes, prostaglandins, histamines, all get released at the site of the injury because now they're exposed to the air, essentially. Now, what do these three things do? One, blood vessels become leaky, or they dilate, blood vessels will dilate. When the vessels dilate, we have increased blood flow to the area. And this is hard to see now. Okay, so increased blood flow to the area, we have more blood in that area, causes the redness, the rubor. Heat, also in swelling because you have blood there. Remember, blood is warm, 98.6. Your skin is not that hot, but blood supply is going to that area now, so it causes the heat to form with inflammation. Let's keep going along. Capillaries become leaky. That's that vascular permeability. When they become leaky, we get edema in the tissue spaces. That causes pain and swelling. Now you're putting fluid, let's say, in a joint, and that joint is not going to be able to move as well because you have all this fluid there. The swelling. Swelling causes pain because the structures can't expand very much. Depending on where the inflammation is, obviously it can be very, very painful, depending on where it is. Okay, now, because we have increased flow to the area, we're going to be able to bring more nutrients and oxygen to the area, to promote healing. We need blood supply with all the healing factors to get to that area. Now, the heat that we get also increases the metabolic rate of our tissue cells. And again, that's going to promote healing. Those cells need to ramp up their activity to heal and repair that damage that occurred. Now, the capillaries becoming leaky also causes clotting proteins to enter the area. Remember, we went through all the clotting cascades. Remember the fibrin, the prothrombin that gets dumped in there, all that stuff. Plasminogen to help with the breakdown of the clot. All that fibrin barrier, again, seals off the area, prevents blood from oozing out still. And because now we're having sealed off the area, now healing can begin. The last thing, obviously, we have our white blood cells. They have to come to the area and clean off that debris and the pathogens. So once they clear it all out, now we can begin our healing process. The last one we haven't covered is that functio laesae, that loss of movement, and it says possible temporary limitation of joint movement. That's if, let's say, you had, septic arthritis of the knee, and the knee is swollen. You're not going to be able to move that knee very much, so you will have loss of movement. The loss of movement, the rest, is our body's defense mechanism of saying to you, stop using this joint. You have to relax this area. We need to heal. If you keep moving, you're not going to heal. So if you ever hurt your wrist or whatever, sprain your wrist or whatever, but you keep moving it, it's not going to heal. You're going to cause chronic inflammation. It will never heal. You're going to cause problems. So the big thing here is understand why we get redness, why do we get heat, why do we get pain, why do we have swelling? Where is it coming from? Why do we get those things to happen? And work backwards and figure it out. That's kind of where pathophysiology is going. We're going to talk about why things went wrong and work backwards and why are they having these complaints? Why do they get swelling? Well, vascular permeability goes up, fluid leaks out of the vascular system into the interstitial space, causing edema, which is swelling. That's why you get swelling. Pain, because all this extra fluid is going into an area, your skin can't, grow anymore. It's going to get very taut. That's when you get that very shiny looking skin, because that skin is being stretched so much from all the inflammation. Causes pain. Redness and heat, increased blood supply to that area, causes the redness and the heat. Okay, last little bit here. These cytokines that are released will have an effect other places in the body. If TNF is tumor necrosis factor, IL are your interleukins. Don't need to know definitions for all that stuff. You'll get it in different classes. But for me, what these chemicals, when they get these cytokines in the blood, they have an effect in other areas. The brain, raised body temp, okay, cause a fever to happen. We have an infection. We have to get rid of this fever. Induce sleep and suppress appetite. See, that's why when you get sick, you have no appetite. Your brain's like, we need to shut off this part. We need to rest. We need to calm everything down. We need to sleep so our body can heal itself. Conservation of heat, so we get shaking chills. Remember the set points change in the hypothalamus, depending on what's going on. We get neutrophils from the bone marrow. Skeletal muscle can cause increased protein catabolism. That's why when you get really sick for a while, you lose all this muscle mass, you lose weight, because your body is pretty much, we need a lot of resources to heal ourselves, so we're going to pull it from the muscle. The liver, so C-reactive protein is a marker of inflammation. So if you're measuring CRP, you're doing it for the purpose of checking, is the body inflamed right now? Is there something going on under the whole situation causing them to have this inflammation? And you also have this elevated SED rate, ESR. Again, these are things that are looking for inflammation. So whenever you see CRP, ESR, those are inflammatory markers. Okay? So I teach at UCF this class, and I inherited from their guy, and one of the activities he made them do was make memes on inflammation. So these are from them. I just thought they were funny. Anyway, those are from UCF students. The last thing we'll do when we take a break is chronic inflammation. This is due to prolonged injury, prolonged infection, sepsis. Again, these are inflammatory processes that should have gone away a long time ago, but for some reason they're still sticking around. Antigens, immune reactions, again, if you don't get rid of the underlying agent, these things will still keep going and going and going. As far as the lesions that you get with chronic inflammation, less exudative, meaning we're going to talk about exudates in a minute, but it's a fluid that we leak out during different conditions. And occurs with fibrous repairs and scarring. Remember, whenever I say you see the word scarring, fibrosis, that's usually chronic inflammation that never healed properly. And once you get scarring and fibrosis, that tissue will not revert back to normal tissue. It's done forever. Okay, well, let's stop here. We'll come back. Take a break. Come back at 10:40. Okay, we'll get started and finish up. So, what did I say? So, moving on, chronic inflammation. We're going to see some tissue, fluid accumulation in chronic inflammation. And there's two different types of fluid accumulation. You have a transudate and an exudate. A transudate is a collection of fluid in tissues or space. Okay, so edema is a form of a transudate. Accumulation of the fluid in the third space, interstitial fluid, increased hydrostatic pressure. Is that the push or the suck? Push. Hydrostatic is the push. Increased hydrostatic pressure, increased push of the fluid into the interstitial space, or decreased osmotic pressure or decreased oncotic pressure. And what kind of pressure is that? The suck. So if you're decreasing the suck, the fluid's going to stay in the space. Not going to come back. Very watery and have a very low protein count with a transudate. Big example of a transudate, CHF, congestive heart failure. Because we have increased blood in our legs, causes increased hydrostatic pressure from all that fluid pushing out, and they get swelling in their legs. An exudate is a result from increased osmotic pressure in tissues due to a high protein content. The etiology of an exudate is usually inflammatory. Okay? Cancers can cause exudates to form. Okay, inflammation. Cancer causes inflammation in that area where the cancer is forming. So you can get exudates there. So let's talk about that a little more. An exudate can be described as serous in quality, fluid, very small amounts of protein, less degree of damage. An example of a serous exudate is a blister. Okay, you wear brand new shoes, they hit your ankle in a wrong spot that you're not used to, chronic inflammation from walking all day, and you get a blister formed. Basically, the two layers of your skin rubbed so much they came apart. And the dermis, the epidermis spread apart, and fluid fills that area that causes blister. Yeah.
So even though there is a small amount of protein, it's because it's localized?
It's because it's less degree of damage is the protein part. Fibrinous. So a fibrinous exudate, large amounts of fibrinogen, that's a scab. Okay, you scratch yourself, scrape your knee, whatever. You get, obviously, scrape, and it has to be healed, and you get a scab formation. That is an exudate. Remember, it's all pussy and everything. Then you have a purulent exudate, and this is pus, live and dead leukocytes. So whenever you see pus, pus is that way because it is all the dead white blood cells in that area. That's what causes the pus to form. You have what's called suppurative inflammation that has increased purulent exudates. An abscess is a localized collection of pus. So if you have an abscess is an exudate that's just filled with pus. An empyema, pus present in a body cavity. Okay, so like in the lungs, could be an empyema of the lungs. It's just a collection of pus. So these are different forms of exudates that you may see as you go through CMS and other things. So like I said before, with chronic inflammation, there's two things that can happen to that tissue. It can regenerate and go back to normal, or it doesn't and it just becomes dead tissue and it scars. So two methods of repair: it can regenerate, which obviously is the most desired outcome. Just think about a fractured bone is replaced by bone, so it repairs itself, it regenerates. But not all cells are capable of this. Cardiac cells and your neurons, they don't regenerate. That's why I said if you have a heart attack, that's it. That muscle is dead, it's not coming back, because cardiac cells do not regenerate. Neural cells do not regenerate. So you cut the nerve, that's it. The other way is fibrous connective tissue repair. So fibrous, scarring, okay, strong bridge across the area, but does not restore original function. So when you have a scar, again, if you have a heart attack and you have scarring of your heart, that part of that heart muscle is not going to work anymore. So therefore, your contractility is now affected because you've lost muscle mass of the heart. We'll talk about contractility again on Friday. We'll bring all that back. So this is what happens with chronic inflammation. It goes back to normal or not. With sepsis, sepsis is an uncontrolled infection, just going rampant through the body. So we'll go through how sepsis works. Okay, potentially life-threatening complication of an infection. Mortality rate, 50% with septic shock. 10% of all ICU admissions are due to sepsis. It's a continuum of physiologic states. First, you get infected. Then your body has a choice. What's going to happen when you have this infection? You get systemic inflammation is the next one down the line of severity. After you now have systemic inflammation, which means that that localized infection now spread to the body. That's why we call it systemic, because now the whole body is affected. That can lead to what's called hypoperfusion. Okay, we're not going to perfuse those end organs as well anymore. The kidneys may get shut off, causing kidney damage. So if you don't have enough blood supply to an area, you can cause tissue injury. Acute renal failure is an example of that. Okay. Now, if you don't reverse things and you keep constantly injuring that end organ tissue, eventually you can lead to organ failure. So this is the severity of what can happen with uncontrolled sepsis. So sepsis is the overwhelming response to an infection. The body kind of goes into overdrive trying to heal itself from that infection. It can happen very fast. These chemicals that are released cause reactions that damages multiple organ systems, leading to organ failure and then eventually death. Because you're killing off your organs, not enough left over. Especially your vital organs, they start getting damaged. Depending on how severe it is, they can't return back to function. You're going to have problems later on. Must be recognized quickly and treated aggressively. You cannot waste time with sepsis. The best thing you can do is just give them tons of fluids. Tons and tons of fluids, just bombard them with fluids. And obviously worry about other things as we go through different CBUS classes. So sepsis, most dangerous to the elderly and people with weakened immune systems. So usually you'll see like who should do certain things. They say people who are immunocompromised or the young or the elderly because they're the both ends of those spectrums that puts them at a heightened chance of becoming septic. So people who have a weakened immune system, anyone in the ICU can become septic. Hospitals are not clean places. Okay, we think they're clean, but you don't want people to stay in the hospital for long periods of time. You want to get them out. And obviously, the ICU is the sickest place, so cross-contamination can occur the longer you are in the ICU. Also, what puts you in the ICU in the first place can also dictate how susceptible you are to sepsis. Extensive injuries like burns. They lose tons of fluids with these massive full-thickness burns. You have all this wide open area. Any pathogen can just fall into that open tissue and cause an infection. They're very, very susceptible to sepsis. And people with invasive devices, IV caths, tracheostomies, if you have a pacemaker and you have wires that go into your heart, anything foreign in the body can become foreign to the body and the body will start attacking it. It can get infected because of the material that's used. Sometimes they get very sticky, and as bacteria come along, they attach to that valve. You'll learn about valve disorders later on. It attaches to the catheter, and once it attaches, it starts multiplying, and if it gets big enough, a certain amount of the infectious agent, then you can get septic from that. People who've gone through like knee replacement surgeries, and then they have an infection, they don't know where the source of the infection is, they don't know where it's coming from. Guess what's coming out of that person's body? That knee. They're taking it out. And they have to like leave the knee open and flush it with antibiotics for a long period of time before they put a new one back in. Because you don't know where the source of the infection is coming from. So anything foreign in the body, you gotta look at it. Like maybe there's an infection on that, we gotta remove it. Risk factor, we talked about already, extremes of age, any genetic factors, and obviously bacteremia. So the stages of sepsis. So these are the actual diagnoses. So this is a very important slide for you to know. Whoever makes your Kahoots or Quizlets, there's 4 questions right off the bat you can do from this one. Very easy, so a little tip for you. So the first thing that's going to happen is systemic inflammatory response syndrome, or SIRS, S-I-R-S. The criteria are at least 2 of the following. To be SIRS, they have to have at least temp over 101 or temp below 96.8. Okay, lack of a fever, too cold can also be a response with sepsis. Heart rate greater than 90. Respirations greater than 20. And white blood cells either greater than 12, which means that we're fighting off an infection, so we need more army units to handle the battle, so we gotta grow more white blood cells, or less than 4,000. If you have less white blood cells than you need, you don't have enough troops to support any battle, you're gonna die. Not die, but metaphorically, you know what I'm saying. Your defense mechanisms can't defeat the pathogen that's coming into your body because you don't have enough white blood cells. So people who have like leukemia or different types of immune problems where their white blood cells are very, very low, they don't have the innate defenses to defend against any type of pathogen. So that puts them at an increased risk for infection because they don't have enough white blood cells. So this is your first diagnosis. They come in, they're feeling sick, may have the flu or fever, like whatever it is going on, pneumonia. You come in, temp's 102, heart rate's 100, you have systemic inflammatory response syndrome. Now, it becomes sepsis the minute you have a culture and you know what the bug is. So whenever someone comes in sick, you order a blood culture because you want to know what bacteria or what is it that's growing that's causing you to have this problem. Usually, we say treatment very, very important early. We start always with like a broad spectrum antibiotic. That's going to cover a lot of different things. Once we know the culture comes back, we usually get a culture and sensitivity report. So the report will tell you that this bug is susceptible to this drug. So you need to switch over to that new drug, or maybe you were lucky and the one that you put them on originally has enough cross coverage to handle that. So it becomes sepsis when you have a documented culture and you know exactly what the problem is. The next thing is called severe sepsis. And this is when you start having end organ dysfunction. Dysfunction, I mean hypotension, or vascular collapse. All those vessels wide open, your blood pressure drops. Hypoperfusion, lack of supply to those tissues. So if you have like lack of blood supply going to your brain, it'll cause confusion to happen, and that's why you get some abrupt changes in mental status. They may also have oliguria and lactic acidosis. What organ are we talking about with this one? Kidneys. Okay, these are your kidneys. Look at that kidney damage. Remember, those kidneys are very susceptible to ischemia. Okay. So, severe sepsis, we have a documented bug, but now their blood pressure is 80/40. You know, they're not making any urine. They're having some signs of end organ dysfunction. Then finally, the last little bit is what's called septic shock. And this is hypotension, unresponsive to fluids. You're giving them fluids like mad. That's why I said in the beginning, they come in, they're septic, they have signs of infection. Just fluids, just give them fluids. If they're sick and they have congestive heart failure, don't care. Fluids, fluids, fluids. You can always diurese them later. Get the fluid off. But they need fluids. You got to give them fluids. If they're not responding to the fluids, now they're in septic shock. And now you got to give like severe heavy hitting drugs to really clamp those alpha-1 receptors. And where are the alpha-1 receptors? Where are they located? The periphery, right? Vasoconstriction. So we have to give them drugs that cause alpha blocking to raise their blood pressure back up. That's when they're in really septic shock. They require support to get their blood pressure up. Fluids aren't cutting it. So these are the different stages of sepsis. Make sure you understand each one. You're just adding another piece of information as you go up in severity. So with regards to sepsis, the balance between the pro and anti-inflammatory mechanisms is lost. Usually we're anti-inflammatory all the time, but during periods of sepsis, the pro-inflammatory side of the puzzle creeps up and we get full-blown inflammation. Blood flow to our vital organs, brain, heart, and kidney becomes impaired. That's why we talked about acute renal failure is usually one of the early signs of sepsis because those kidneys are very susceptible to ischemia. Clots can form. Okay, in sepsis, one of the big side effects are clots, and they'll throw clots like crazy because they're tipping the scales to more pro-clotting. Right now, we are all anti-clotting right now. We don't want our blood to clot. So the anti-clotting mechanisms are in control over the pro-clotting mechanisms in our body right now. When they aren't in sepsis or any type of genetic abnormalities that you may have underlying, if you have bleeding problems, but in regards to sepsis, they get clots throwing because they're in a clotting environment. If the clot happens in an organ failure. If the clot happens in your extremities, you get gangrene, which we've already learned about gangrene, lack of blood supply to an area, ischemia, tissue dies off. Okay, so again, this is just talking about how homeostasis is lost in sepsis. We are tilting, the heavier side is the coagulation and inflammatory side. We tip the scales to that end. We don't want inflammation, we don't want clots, but sepsis puts us in that environment. Okay, most likely, who gets septic? Pneumonia, abdominal infections. They're considered dirty infections. UTIs. Now, UTIs are very malicious because elderly people will come in with altered mental status all the time. You have to check a UTI first. Any elderly patient coming in with altered mental status, confusion, they look like they're sick, in the elderly, check for a UTI. They get them frequently, and if they build up too much, they cause altered mental status just from a simple UTI. You give them some Cipro, Bactrim, and they're better in 2 days. But if you didn't check for a UTI first, you'd be thinking, oh my God, blood cultures do everything. What's going on? This patient's dying. No, he just has a UTI. Just treat it. And then bacteria. So these are the signs of sepsis. They make up the word sepsis. Again, whatever you want to use to remember things is fine by me, as long as you remember. Why is it cutting off again? Okay, hang on. 66. Okay. So, common complications. DIC, disseminated intravascular coagulation. This is the clotting problem. Okay? They throw clots like crazy. It's called disseminated intravascular, inside the vessels, coagulation. We're clotting. Remember, during sepsis, we are pro-clotting, pro-inflammation. Pro-clotting, disseminated intravascular coagulation. Acute respiratory distress syndrome, they're septic, they got pneumonia, they can't breathe, you have to maintain airway support, so you may have to ventilate some of these people due to the ARDS. Acute kidney injury, remember, due to ischemia. Those kidneys are very susceptible to changes in blood flow. They become ischemic very easily, causing acute kidney injury or acute renal failure, whatever you want to call it. And obviously, hemodynamic compromise, that is your low blood pressure. Vessel just wide open, pressure drops too much. So treatment, RX cultures, find out what's growing, give them volume, resuscitation is the big one, antimicrobials, and here's your vasopressors. Remember I said, what's the very, very last phase of sepsis, the most severe one? Septic shock. And what is the requirement for septic shock? What don't they respond to anymore? Fluids. So you have to give them a vasopressor. Norepinephrine. Remember, what does norepinephrine bind to preferably? Alphas or betas? Alphas. And where are alphas located? The peripheral vascular system. So if you get norepinephrine out there, it's going to do what to those vessels? Constrict them. And if we constrict them, what happens to the pressure? It's going to increase. And that's what we need, and that's what we want. Increase in pressure. So if your patient is not responding to fluids anymore, you have to give them vasopressors. And those are the drugs, norepinephrine, going to target those alpha 1s, vasoconstriction, to get your pressure back up again. Do you see how everything comes back to physio, pulls up? Pull it back all the time. If you're confused, just go back to the videos. They'll be there. I'll post these videos. Go back. It all comes back. I'll even go back, like neuro, I'll go back to like what we learned day 1 in physio because it's relevant again. So it all comes back. Okay, next section is on immunity. So we've already gone through all the inflammatory processes, know about acute and chronic, and the major differences between the two. Now moving on to immunity. Remember that with our cell-mediated immunity, the T cells are from the thymus gland, and the B cells are from the bone marrow, from the bone for B lymphocytes. Okay, so let's talk about different types of immunity. We have our external innate immunity. That's our skin, digestive enzymes, and respiratory tract. Anything that comes to exposure to the outside environment, but it's on our bodies, is an external thing because external comes in. So skin, digestive tract, and respiratory. The ways 3 things can get into our body. Our internal immunity, our phagocytic cells, interferon, natural killer cells, and our mast cells. These are our innate internal immunity system. We can also gain immunity actively. Okay. produced by the individual or given to them directly. And these are naturally and passively acquired. Okay. Then we also have passive immunity, and these are preformed antibodies or T cells are given from the donor to the recipient. So we're actually giving you the antibodies now. You don't have to do anything for it, like rabies. We don't need, like your dogs obviously need rabies shots because they're potentially could be attacked by other dogs. Humans don't need a rabies shot because hopefully you don't get rabies. But if you do get bit by a dog or an animal that you suspect to have rabies, they're just going to give you the antibodies for rabies to you directly. There's no reason for us to develop immunity. Snake venom, the antibodies for the snake venom, we just give them to you because you don't need to develop immunity for that. Some people want to, and they do crazy stuff. But anyway, we can give them to you. So here's just an arrow, like a summary slide that talks about the different types of adaptive immunity. So let's talk about immune functions. So there's two classifications when we talk about immunity. Immunodeficiency diseases, where we don't respond to foreign agents, so HIV or AIDS, acquired immunodeficiency syndrome, poor response to foreign agents, and then the opposite, your hypersensitivity reactions or an allergic reaction is too much of a response to the antigens. So these are opposite things. Immune deficiency, we can't respond to a pathogen. That's why people with HIV/AIDS, they die from like pneumonia, something simple, because they don't have any defenses anymore to handle those types of infections. So we'll get to AIDS tomorrow, HIV. So hypersensitivity is really a broad term than an allergy. There are 4 different types of hypersensitivity reactions. And we're going to go through all 4. So first thing, autoimmunity. These are your autoimmune diseases. Okay, they help regulate our immune system. When they're disruptive, okay, we get uncontrolled production of autoantibodies. Auto because they're going to attack the self. Or abnormal cell-to-cell recognition leads to tissue injury. And that causes an autoimmune process where your body attacks certain tissues because they think it's foreign. That's what an autoimmune process is. That your body just attacks itself because it sees it's foreign. So essentially, autoimmunity is a hypersensitivity to the body's own components. Just the body itself, it reacts to it. And it's mediated by your lymphocytes or antibodies. So one type of alloimmunity is when one immune system reacts with another one. An example of this is your transfusion reactions. Remember we talked about A, B, ABO, and the positive and negative for the Rh factors. You have to type and screen before you put blood of someone into someone else. If you don't do that, you can cause a transfusion reaction. You get agglutination and binding. All of those red blood cells, they clump up, and then that's a transfusion reaction called hemolysis. A lot of problems happen downstream from that. So one form of an alloimmunity problem is a transfusion reaction. Different blood types are mixing. They cause agglutination. Another one is called graft versus host disease. Normally, if you get a transplant of an organ, liver, lungs, whatever, what they do is they usually knock out or condition the host person's immune system. Either through drugs or radiation, we want to knock out their immune system because we don't want the host to attack the new organ as being a foreign substance. So we kind of knock out your immune system so you don't attack the new organ and your body gets used to it and you're okay. One of the things that can happen is called graft versus host disease. Usually, if you have a reaction to a transplantation, it's usually you rejecting your new organ. And when that happens, you just take that organ out, if you can, and then wait for a new organ to come in. Sometimes you get what's called graft versus host disease. It's rare that it happens, but in these cases, the new organ that you put in gets metabolically active and starts producing its own immune reaction to you as the host. So what's happening is you're getting mixture of all these antibodies, that's going on, and what happens is the transplanted organ rejects the host. And unfortunately, there's nothing you can do for that because you're mixing immune systems and you'll never know which ones are yours, which ones are the organ. And unfortunately, it leads to end organ failure and they pass away. So there's nothing you can do because the organ is attacking the body. And where are you going to stop it? You can't take the organ out because the immune system is already in you, causing problems. So this is one other form of alloimmunity, graft versus host, where the graft, the new transplant, rejects the host. Okay, hypersensitivity immune responses. Okay, so this is, think about if you get like bee stings or if you're allergic to peanuts. Every time you have an exposure to that allergen, the reaction gets worse because you've already been primed for it, and every time you get exposure to it, your body overreacts to that antigen or that insult or whatever it is. So your body just overreacts every single time. It's a hypersensitivity reaction. Hypersensitive, we overreact to a simple thing. Strong genetic components with this. So there are 4 types, and we're going to go through all 4. And there's an easier way to remember these things. And I'll do it's A, C, I, D. Remember acid. As we go through them, you'll see why I put acid there. So type 1 is IgE mediated. What is special about IgE? What I told you, whenever you see IgE going up, what does that mean they're probably having? Allergies. So IgE is for allergies, and that's why it's A. So think of allergies, A to P, and we'll go through the other ones in a minute. The next one, type 2, antibody-mediated, cytotoxic, cell-mediated. That's why it's C for type 2. Type 3, immune complex-mediated. So you get antibody-antigen complexes, they get together, that's the immune complex, and those get deposited into your tissues. That's a type 3, I, immune complex. The last one, T-cell mediated or a delayed hypersensitivity reaction. Type 4 is your delayed reaction. Okay, any girls or I'll say anyone, guys or girls, wear fake jewelry and get that reaction on you afterwards? That's the delayed type 4 reaction. Your body's reacting to the cheap nickel in the gold. So, okay, type 1, IgE mediated. The 2 types, atopy and anaphylaxis. Okay, peanut allergies, insect bites, stuff like that. Again, IgE mediated. So IgE is always allergies. Just remember allergy. Vasoactive chemicals, mast cells or basophilic leukocytes. What do mast cells make? Histamine. What happens when you have an allergic reaction? Start sneezing, snot's running down your nose, right? From the histamine that's released, and that's why you take an antihistamine for help with allergies, because it's going to block the histamine response, and you don't get all that leaky fluid. Reaction occurs within minutes to hours. Oops, sorry. Minutes to hours. Again, if you've gotten bee sting or whatever, if you eat peanuts, you're allergic to that, you start feeling it pretty soon. Shrimp, allergies, whatever. What are the signs and symptoms that could be included in a type 1 urticaria skin? What is that? What's urticaria? Itching or hives. No, pruritus is itching. Urticaria is hives. Eyes, conjunctivitis, that injection into their eyes from the allergic response. Rhinitis, rhinorrhea, asthma can happen as an allergic response to an antigen or an allergen that goes into your bronchial pathways, can cause a hypersensitivity reaction and you get asthma. That's why a lot of the triggers for asthma, smoke, animal dander, those things are like allergy. I don't ever do those allergy tests, the patch test. They're trying to see which ones promote cause the localized reaction. You see the skin getting really inflamed and red because you're allergic to that stuff. Gastroenteritis is also a sign for allergies. It can happen as well. So A to P is a group of diseases: allergic rhinitis, asthma, dermatitis, and your gastroenteropathy. Again, your triggers: pollen, mold spores, animal dander, dust mites. So this is what A to P is, or atopic dermatitis. How is this a baby? That's why with babies especially, you have to give them one food at a time. Whenever you introduce them to like real food, not the baby food, one food at a time. Because what if I give him strawberries, blueberries, and bananas, and he has this reaction? I don't know, was it the bananas that caused it, the strawberries, or the blueberries? So you always introduce one food at a time, see how their body reacts, because they get all this. Anaphylaxis is the most severe form of hypersensitivity reaction. Obviously, mast cell mediators are going to be here causing a systemic anaphylaxis. When this happens, you get hypotension and shock, bronchospasms, maybe GI urine contractions, urticaria, or angioedema. Angioedema is swelling of the lips and tongue. What complication can happen if you have too much swelling of your lips and tongue? Airway complications. You gotta maintain that airway. So they have problems breathing because of all the swelling. Can be fatal, obviously. So anaphylaxis, again, here's your urticaria, your hives. Most common causes of anaphylaxis, your drugs, antibiotics, penicillin's a big one. That's why you have to ask about what happens when you take these drugs that you're allergic to. If they say, oh, I take penicillin and my stomach hurts, that's an adverse reaction. That's not an allergic reaction. If they take penicillin and I can't breathe, yes, that is an allergic reaction to penicillin. Don't take it. But if they say, oh, my stomach hurts a little bit when I take the medicine, that's an adverse reaction to the drug itself, not an allergic response. Radiocontrast agents. Be very careful with contrast dyes. They can cause allergic reactions as well. That's why you have to ask about allergies to what? Shellfish. Because there's cross-reactivity between shellfish and the contrast dye. Antineoplastic drugs, NSAIDs can also cause it. Insect venoms, latex. And if you have a latex allergy, let us know so that we get you the right gloves. We do have non-latex gloves for like CPSS because you have to wear fitted gloves for surgery. When you go for surgery, they'll have latex and non-latex gloves for you. Obviously, foods. This is where your peanut allergy comes in and other things. So here's your anaphylactic reaction. This is angioedema, and obviously the swelling of the tongue. Obviously, they're going to have very, very hard time breathing with all this, so you really have to make sure that you're watching these patients, making sure their O2 sat is still good, so they are getting adequate enough breathing and enough oxygen. So signs and symptoms of anaphylaxis: fainting, lightheadedness, erythema, angioedema, laryngeal edema, so they have swelling of the throat. Again, airway response, how well is their airway going? Sense of impending doom is a big one. They may feel like, I'm dying, this is the end. When that allergy response starts kicking in. Can also lead to loss of consciousness and death. We'll stop here. We'll pick up type 2 tomorrow. Okay. Gonna do a long break.